Welcome to the episode, The Role of Endodontics After Dental Traumatic Injuries. How to deal with the dental-pulpal complex when it becomes affected by a trauma. When the dental trauma happens, we must first do a vitality test, a thermal or electric, and we must write it precisely in order to know the progression and the success rate of our treatment, because the transition from a negative response to a positive response may be considered as a sign of a healing pulp. On the contrary, the transition from a response to no response may be that the pulp is degrading and it is becoming necrotic. The follow-up at first is after 3 months, then after 6 months, then after 1 year. Then the radiographic examination to know the site and the direction of the injury that is happened, also the extent of it, and CBCT surpasses the 2D radiograph in this situation. Here we can see the lateral luxation that is affected the two centrals. Also this is a luxation. We can see how it is out of the socket. Then the physician tried to do an emergency return for the tooth and used a flexible splint, but we see that the return was not in the right place, so we did remove the splint. This is the composite in it, and returned it to the place. We can see how there is a great gap between the place and where the right place and where it was splinted. Here, for example, there was a fracture in the mandibular tooth, and it was associated with this injury in the lip. After 2 weeks, the injury did not get healed. So we did a radiograph and we saw that part of the tooth broken was inserted into the lip. So it was removed, and we can see the healing has happened afterwards. So this is the importance of the radiograph. We can see here that the 2D graph did not show us the extent of the fracture, but the CBCT did show us the extent of it. Usually these traumas happens in young adults that are in age between 7 to 12 years old because of accidents in home or school. The primary teeth that are affected are the maxillary anteriors more than the posteriors or the mandibular anteriors. Also, if you were able to perform a quick and correct treatment, the outcome is in most of the cases is very good. The most common types of dental trauma are the crown fractures, the root fractures, and the luxation injuries and avulsion. For the crown fractures, if it only affected the enamel and dentine, we call it an uncomplicated crown fracture. And the treatment is quite simple. We first must close the exposed dental tubules by doing normal composite restoration, or if the dentine is also exposed, we can do, and the remaining thickness of the dentine is low, we do a full restoration like a crown or a bridge. But we cover the pulp with calcium hydroxide or MTA as a layer between the 0.5 millimeter of thickness of the dentine and the pulp in order to not get any irritants from the restoration that we will be applying afterwards. If the fracture involves the enamel, the dentin, and the pulp, it is now called a complicated crown fracture. The procedure depends on the situation of the tooth. If it is mature, which means that we have a closed apex, and if it is immature, if it is open, we should not leave it without any treatment because it will result in a pulp necrosis. So, if the tooth is immature, we do a pulpectomy, a pulpotomy, which means that we remove the coronal pulp in the chamber and we leave the vital pulp in the root in order for the root to continue its growth and close the apex. As for so maintaining the vitality of the tooth in immature tooth is important to continue the growth of the apex. Now let's discuss the requirements that make the pulpotomy is the choice of our treatment for the traumatized tooth is that only 48 hours is passed on the trauma accident. We must have a plan of the future plan on how we are going to restore this tooth. If you are going to restore it with a composite resin restoration, which means there is a simple loss in the structure of the tooth, we can do the pulpotomy for sure. But if we are going to do a crown or a bridge abutment, pulpectomy is our choice of treatment. 24 hours is the optimal time on which we do the pulpotomy after the trauma has happened. We must be sure that we have a bacteria tight seal when we are doing the procedure. Then we must do the dressing, which can be calcium hydroxide or MTA, that is applied to that is applied directly to the pulp tissue, and it causes 1.5 millimeter of necrotic pulp tissue because it enhances an inflammatory response that causes a coagulant necrosis in the pulp, and it protects the underlying pulp tissue. So it initiates a hard tissue barrier that we called the dentinal bridge, that is a radio opaque line, or we can use an MTA that gives a great seal against the bacteria, but we know that the two disadvantages is the discoloration, which means that we may need an internal bleaching afterwards, and the prolonged setting time, which the biodentine surpasses the MTA in this characteristic that it sets quickly enough for a one-visit procedure. The success rate is 95% when we do the pulpotomy, which is the 𝐏𝐻𝐿 pulpotomy. This is a case. We use high-speed diamond burr, and we remove 1 to 2 millimeters of pulp tissue. Then we insert calcium hydroxide or MTA, as we said before, directly in the pulp, and we must be sure that we do not touch the walls of the tooth. Then we put glass ionomer After that, we close it with a composite restoration. As we see after 6 months that the bridge has been built. Doing this procedure can also enhances the growth of the apex. There's a philosophy that says after we do the pulpectomy and the tooth continue its development and there is an apex closure, we do a full pulpectomy and remove the whole pulp, and this has happened after 18 months when the apex has closed. Their evidence is that saying that the pulpectomy procedure having a success rate in the range of 95% when before the necrosis. But if we left the tooth and it became necrosis, then we do the full pulpectomy, the success rate decreases to 80%. This is their evidence. It's an opinion. Now let's talk about the root fracture. Pulps in root fracture teeth will survive this rather dramatic energy. This is surprising. The apical segment stays vital, which means that if the tooth, in most of the cases, it stays vital, and if it responds to the normal vitality tests, there is no need for an endo treatment. We do a flexible splint for 2 to 4 weeks after we return the two parts to each other. There are 4 cases of this returning that may happen. The first case of healing with a calcified tissue with internal thickening of root dentin. The second, this is the A2. This is one, is the bone forming. Number B, this healing with a connective tissue. C, healing with bone and connective tissue, and we can see here the apical calcification in this teeth. This is number D, where there is no without healing. There is no healing. The 3 cases here are a sign of success. The third one, this, the fourth, is not a good sign. And these tooth normally they respond well to the vitality test and they are asymptomatic. They need no treatment. The reason that in this case 4 we did not get a heal, this means that the coronal part became necrotic due to the injury that happened. For example, this fracture that happened, we have seen that the tooth was repositioned, the segments, and splintered to the lateral incisor with a composite restoration. At 6 months, we have seen that it a starting of an internal resorption, but the tooth was asymptomatic and it responded normally to the cold. So no treatment was indicated. So after 3.5 years, we can see that the internal resorption has stopped and the apical area became calcified. The tooth was also asymptomatic and it responded to the vitality test. So there is no, this is an indication that we are getting a healing and there is no need to do any endo treatment. Now let's discuss the luxation injuries. There are three types: the lateral luxation, the extrusive luxation, and the intrusive luxation. Often, the luxation's injuries result in a necrotic pulp because it damages the cemental, also the periodontal ligament. So, an endodontic treatment is critical to prevent any resorption that may happen. Teeth with lateral and extrusive luxation should be repositioned as soon as possible. We do a splint for the lateral luxation for 4 weeks and 2 weeks for the full extrusion luxation. Here we emphasize on the important on doing the endo treatment after we do the returning of these tooth, the luxation tooth. We have seen in this case that the tooth that did not get an endo treatment was undergoing an internal resorption due to the necrotic pulp that had happened. So after 7 to 10 days of the injury, we must do the endo treatment. It is advised to do calcium hydroxide as a dressing, an intracanal dressing, and do the treatment in 2 visits. Now let's discuss the clinical management of a fully avulous tooth. The replantation is the optimal replantation is between 15 to 20 minutes after the accident. If there is no near dentist, we can preserve the tooth in milk, saliva, or physiologic saline and water. Water is the least desirable storage medium because it causes a rapid cell lysis and increases the inflammation when we do the replantation. The steps are: we prepare the socket by cleaning it from any debris. We prepare the root. We will see how. We do the replantation. We construct a functional splint to preserve it in place. Then we do an antibiotics. And after 7 days, as we said before, we do the endo treatment. Now, the periodontal ligament cells, they can stay vital only for 60 minutes out of the mouth. So the prognosis of the treatment is determined by the time, the 60 minutes that we have. If the extraoral dry time is less than 60 minutes and the apex is closed, which means that the tooth is mature, there is a chance for the periodontal healing to exist. So we replant it in its place, and a healing would be expected. As for an open apex, we soak it with doxycycline for 5 minutes or cover it with monocycline like this, a powder, and we do the replantation, and the prognosis is really good for the open apex. Now, if the extraoral dry time is more than 60 minutes, for a closed apex, we remove the periodontal ligament because it is dead now by placing the tooth in an acid for 5 minutes, soak it in fluoride, and we replant it. We can do the endo treatment extraorally. As for the open apex that exceeded the 60-minute range, the prognosis is poor, and some physicians, they do not recommend that we do the replantation. What we mean by preparation of the socket, that we remove any obstacles that may be in the socket, and we remove the blood clot that has formed in order for the tooth that can be placed properly in it. For the split, we use a flexible 0.4 millimeter in diameter splint, and we fixed it with the glass ionomer or composite on the tooth. We leave it no more than 1 to 2 weeks when full avulsion happens. Even if after we removed the splint after 2 weeks and the tooth is having a class 1 or 2 movement, it will regain its rigidity without the splint, so we must remove it after 2 weeks of fixation. For the antibiotics that we prescribed before, the reason is to subsequent the inflammatory resorption and to prevent the bacterial invasion of the necrotic pulp. We can prescribe the tetracycline, the doxycycline, the penicillin. The tetracycline, they delays the resorption because it affects the motility of the osteoclast. We also prescribed chlorhexidine rinses for 7 to 10 days. The second visit is after 2 weeks of the trauma, where we remove the splint. For avulsed primary tooth, we generally do not replant it. Now let's go to the summary. Managing dental traumatic injuries. Crown fracture. If only enamel and dentine are fractured, composite restoration or full crown is sufficient. If the fracture included the pulp, we perform pulpectomy for immature tooth and pulpectomy for mature tooth. Root fracture. We return broken parts and do a flexible splint for 2 to 4 weeks. Bone or connective tissue, or both, can fill the junction. No endodontic treatment is indicated if tooth responds to vitality tests. Lateral luxation. Return tooth to place and fix it with a flexible splint for 4 weeks. Avulsed tooth. If the tooth is immature and stayed out of socket for less than an hour, we return it after covering it with minocycline. If it is mature, we return it also to the socket. If tooth is immature and stayed for more than an hour, we do not return it. If it is mature, we remove the periodontal ligament and return it to place and give antibiotics and do a flexible splint for 2 weeks. After 7 to 10 days, we do endodontic treatment.